X-rays interpretation by University of Michigan Medical Center. The objectives of this lecture is to discuss background, types, technical qualities, A, B, C, D, E, F mnemonic, case studies, and question answers. History. By accident in 1895, by German scientist William Conrad Roentgen, was able to see opaque items such as bones and foreign bodies. First X-ray made public January 23, 1896, used in 40 and 50s to fit the shoes. How it works? So basically this is the X-ray machine from where the electron beams are passed, and then this electron beams are okay. These are the five colors which differentiate the different elements of the body. Like air is the black and metal is white. Bone is half white, fat is lighter than black, and soft tissue is gray like. This is the tissue densities. Number one, look at one, that is air, which is black in color, fat lighter than black. Look above the clavicle, which shows us the fat. Third, soft tissue and bones, which are a little bit dark, half white. Positions. There are different positions of X-rays, which includes anterior posterior position, posterior anterior position, lateral, supine, and upright. Positioning example. So this is anterior-lateral chest X-ray. Project cone-shaped image, convert 3D to 2D. Big impact. AP versus PA. Distance plays a big part. AP 40 inches optimal. PA 70 inches optimal. PA is industry standard. Lateral views. Clarifying of significant findings should not be routinely done. Supine versus upright, used primarily to assess chest fluids level. Supine allows for full expansion of chest, lungs, standard day for chest X-ray. Assessment of quality, rest in peace. Rotation, inspiration, penetration. Spinous processes should be midpoint between clavicles. Inspiration 5 to 7 costal spaces present at the mid-clavicular line. Penetration, can the spine be visualized behind the heart? Rotation, spinous process. This is the spinous process. These both are medial clavicles. Below ribs, heart, trachea, gastric, diaphragm, cardiophrenic and cardiothoracic angles are mentioned. Inspiration. Diaphragm is moving above consolidation, clavicle, ribs, and this is basically posterior anterior view. Inspiration. 1, 2, 3, 4, 5, 6. Diaphragm, midclavicular line, no consolidation. Expansion. So this is expansion X-ray. Penetration. Is there any penetrating ABCD, a systemic approach to reading X-rays? Airway, bones and soft tissue, cardiac silhouette, diaphragm, effusion and fields. Airway. Anatomy. Right main bronchus. This is trachea. This is left main bronchus. Bones. Four main bones to identify: clavicle, ribs, vertebral body, sternum, heart to distance, cardiac silhouette, mediastinal interpretation, ascending of aorta, right pulmonary artery, right atrium, aortic arch, aortopulmonary window, left pulmonary artery, left atrium, and left ventricle. Diaphragm, right elevated by the liver. On right side, it is elevated by the liver. Costophrenic angle, which are on the side, and there is a gastric bubble. Effusion, assess pleura to ensure full expansion. Right hemidiaphragm, left hemidiaphragm. Fields, oblique fissure, horizontal fissure, superior lobe, middle lobe, and inferior lobe on the right side, superior lobe and inferior lobe on the left side. Devices, gastric tubes. When there is some NG near the gastric tube is passed, so it will be shown in X-ray. Devices like ETT placed into tracheal tube is placed, so it can be visualized. ET tube, trachea, cuff 5 to 5 centimeter before the carina. Devices, CVL. When there is a device placed like CVL, so it will be seen on X-ray. Device is chest tube. So this is basically the chest tube placed in the chest X-ray. Cardiac device like pacemaker is installed, seen on chest X-ray. Now it's test time. So what this X-ray is actually showing. So this is X-ray. First of all, A for airway. Look, the trachea. Trachea is slightly deviated. There is left and right bronchus. Now look towards bones and soft tissues. So clavicle is, look towards clavicle, then towards the ribs, sternum. Now comes towards C, cardiac shadow. It's cardiac shadow. Now comes towards fields, E, effusions. So there is mild effusion, but this X-ray is not completely showing it. Now look for fields. Now look for the devices. So here a device is placed which is seen on the X-ray. This is basically another X-ray in which there is a lot of infiltrates, patches, consolidation, and a ETT is passed. This is another patient in which there is left lung is completely collapsed, and the right lung is showing infiltrates. This is another lung in which a device is placed. This is another chest X-ray which is also showing some devices are placed. This is chest X-ray showing consolidation. This is another chest X-ray having effusion. This is another chest X-ray in which the chest tube is installed. Another chest X-ray having effusion. This is full of effusion, infection, pneumonia, aspiration pneumonia. In this X-ray, left lower lobe is damaged. This chest X-ray is showing that clavicle is fractured. This X-ray is showing infection in the lungs. This chest X-ray is showing haziness in the lungs, maybe infection, and chest tube is placed.